on family support and training. My name is Dan Ferris. I'm with the Managed Care Technical Assistance Center. I'll be joined here today by Boris Filgorin, also of the Managed Care Technical Assistance Center. Just a couple of housekeeping items to talk folks through if this is your first time joining us for a MCTAC webinar presentation. We're thrilled by the response this series of webinars has received. We have over 1,000 people registered for today, and are really excited for so much participation and a robust Q&A at the end. So just again, for the third time, if you're just joining us, the slides are available at mctac.org on the events page if you're the sort of person who likes to print those out and jot down notes as we go along. Next week, a recording of this presentation will be made available also at mctac.org. And for the Q&A today, you're welcome to submit questions as they come to your mind. We actually encourage you to do that. You can use on the right-hand side of the screen, there's a little chat box, and we encourage you to chat those to all panelists, if you don't mind, so we can get a sense of the questions that are coming in. And then we'll be keeping those on our end here, trying to consolidate and combine so we don't ask the same question 5 times, and our esteemed panel will be chiming in as best as they can towards the end of the webinar. Speaking of our esteemed panelists, so again, I'm Dan Ferris, and I'm joined here by Boris Filgorin. We have Yumi Ikuda from the New York City Department of Health and Mental Hygiene. She is the Director of Rehabilitation Programs, which the role sits in the Bureau of Mental Health Office of Rehabilitation. We have Brenda Harris-Collins, who's an Addiction Program Specialist in the Practice, Innovation, and Care Management Division at New York State OASAS. And then we also have Kinsey McManus, who's Services Director at NAMI NYC. So I'd like to just take the moment to thank our presenters for joining us today. So very quickly, just a short overview of family support. It's an important component of the home and community-based services package, the goal being to assist individuals who wish to have their family of choice educated and supported with respect to the individual's ongoing recovery. It's centered around an individual's plan of care, and it's distinct from freestanding family support. So with that, and to give a little more context on what all of that means in the world, I'm going to turn things over to Yumi, who's going to take it from here.
Hi, folks. I just want to clarify, some people might have been confused with the title slide where it says Adult Home and Community-Based Services. Some people might have translated it that way, but it's Home and Community-Based Services for adults is what we meant. So let's go to the next slide, and we'll get into the nitty-gritty. Can somebody advance? Hello? Okay. So, as you probably all know, Family and Support and Training is one of the HCBS services, and it's sort of like in the bucket of other types of support services that people can take advantage of. Next slide. So as you can see, many agencies are very interested in providing this service, so it will be one of the key ones that we believe will be requested. These are the services that can be combined with family support and training. As you may know, some services aren't combinable, but this particular one, as you can see, can be combined with OMH clinics, OASIS clinics, OASIS opioid treatment programs, OMH partial hospitalization, and OASIS outpatient rehab. Oh, I skipped one, OMH, the IPRT and the CDT programs. Next slide. Okay, so support and training. Some of the key components that fall under this particular service is that training, particularly for family, and support for family that's centered around the need of the individual. So, you know, some of us, I'm a consumer, some of us don't want our immediate family involved in our care. But for those who do request it, in order to help supporters understand better and know how to support us, is a key component of our recovery. And obviously, we would want that service to be provided with a very recovery-oriented approach. In other words, you know, that they should educate and support parents with the philosophy that everyone can recover from their disorders and illnesses. And many of us, of course, have been through trauma, which affects our condition. And so we want to have that lens in terms of when our loved ones, our supporters, are being educated. And so, you know, for some people, obviously, family is defined differently. But basically, we're talking about the family of choice. So what I consider my family, it's my boyfriend, my very close friends. For some people, it is their parents, their spouses, children, of course, need to be educated on how they can support their parents, relatives, foster families, and in-laws. So, you know, it's all encompassing in terms of who can actually support the individual, and of course, it's defined by the individual. Now, when we say it doesn't include individuals who are employed to care, some folks may have home health care folks who may assist them with different supports. Those are folks typically who are being paid to support the individual. So the service will not cover sort of educating and supporting those folks who are paid to care for the individual. In terms of training, this is not totally comprehensive, but of course it includes, you know, solid, hard education, if you will, about treatment regimens, different elements of recovery, different options for support, individual support, sometimes it's peer support. There are very specific concepts, as I mentioned, recovery orientation, person-centeredness, that should be also educated in terms of, you know, a lot of people who are not in the mental health field don't really understand these concepts. Also, education about medication and different options in that area. But again, everything feeds into the individual's desire and choices. Next slide.
No, Yumi?
Yes.
Okay, this is Brenda Harris-Collins, and thank you, Yumi, but I wanted to also just, from the Oasis perspective, kind of speak
Absolutely.
on, if that's all right, speak on family support and training, and just want to say that, you know, for the substance use disorder side, that is very important. This is extremely important for our individual persons that are in recovery. According to SAMHSA, there are 4 areas that support a life in recovery, and one of the areas is home, and that which includes family. And previously, some years ago, I ran a focus group with families in recovery from addiction services, from addiction, and one of the areas that was most identified for persons in recovery was the area of family and how the impact of their family, maybe not understanding the recovery process and the importance of their family receiving and understanding what the recovery process is and the impact that it has on their recovery process. So for us, as addiction professionals and in the substance use disorder industry, it is extremely important, and we're really excited about having family support and training being one of the services. Thank you.
And Brenda, also, correct me if I'm not mistaken, but I think that the philosophy of harm reduction, is that also key?
Yes, very key to understanding that, you know, so many people view recovery as abstinence, and that's not the correct view, and a lot of families don't understand relapse as well, and they think that that's the end of everything, and that the person is still doing, and understanding for some individuals that relapse is a part of their recovery process. We look at recovery being long-term, and that it is a process for a person to go through. So yes, it is extremely important to be able to convey these types of ideas to the family members.
Right. So as I mentioned before, the different trainings, the topics, they're covered at the top bullet again. But basically, it's, you know, also to assist the family in providing a supportive environment to the extent that, you know, the individual should feel comfortable and not judged about their situation, their feelings about situations, and so that also is a very key concept. The services themselves can be provided one-on-one, in other words, you know, with a counselor or a peer specialist, with the individual and also with the individual and their family of choice members. And they could also facilitate support groups. Now, the support group, of course, you know, is for helping the individual. So the support group may include the actual individual if they are okay with the family members being in the same group. That's fine. And what we meant before about freestanding family support, it's not support that's focused on the family, but it's focused on the individual and how they want the family to be supported. So if you're having a group, the topic should be around whatever is included in the individual's plan of care that's been developed with the health home care manager. So it's not a free-for-all sort of general support group, but with a very specific topic that is discussed.
And Yumi, I totally agree with what you've been saying, and also in regard to the components, especially assisting the family to provide a safe and supportive environment. Many times there's a lack of understanding of substance use disorders, as we said, amongst the family, and the need for a safe and supportive environment. And for example, in addiction and substance use disorder arena, many times families don't understand, even if the person has alcoholism, that maybe in the household they may need to be locked, the alcohol needs to be locked away, or prescription meds should not be left out. They need the understanding of that the person may have to remove themselves from a family event, and they need to provide support. You know, many people with addictions, they have issues of going to family events such as weddings and need a very supportive environment, and also helping families to understand the different levels of care and principles of hope holistic, and that recovery is self-directed. All of these kind of things help really provide a safe and supportive environment, and that's one of the components of this service.
Yeah, I agree with that. I myself volunteer to facilitate family and friends support groups, and that's one of the key things that constantly comes up, and they want to learn how to help the individual using those concepts. Okay, next slide. Okay, here's some other services that fall under this category. As you know, there are situations where there's conflict between the individual and the parents and, you know, the individual's decisions about their recovery path. So it's good to have somebody who can mediate and be able to have a productive, or let's say conducive to a productive and supportive conversation. And a lot of times that third party, objective party, helps a lot to have that kind of discussion. There may be also, the individual may see that the family has particular issues with strategies on how to help the individual. A lot of times what I witness in my groups is that parents want to, they go to one extreme where they say, well, I should allow the person to, the loved one to do whatever they want, because if I don't, then the situation will get worse, and you know, they're not quite sure how to navigate that and solving different issues and how they can cope with the situations themselves. And oftentimes, obviously, if an individual wants their family of choice to be involved in their recovery, they also want to make sure that the family of choice are supported to be able to help the individual. The other thing that's important is the collaboration, okay? This service, and none of the services, should be in isolation of the individual, who is the main person, and to collaborate not only with the family, but other caregivers that the individual may want to be involved in the conversations. It's also, as we mentioned before, a lot of it centers around education and helping the family to understand, you know, specifically what their loved one is going through and how to cope and support in a particular situation, whether it's harm reduction and the individual is trying to stop using substances or trying to control their anger. There are different ways to help the family sort of in a supportive way to help the individual. There are also opportunities to provide trainings, specific trainings and workshops in a formal, let's say, environment, and it can be attended by the individual or not. But again, the topic of these trainings and workshops should be relevant to the individual's plan of care. So it shouldn't be in isolation of that. Next slide. Go ahead.
I'm sorry. So just for substance use disorder services, this is a big area, so I just wanted to, for those who are on and are looking at substance use disorder and serving those individuals, substance use brings a very unique view of this, because due to the substance use of an individual, the hurt and pain experienced many times by the family is great, and reconciliation is really a big piece of the person's recovery process. So family mediation and conflict resolution is really important to the process, and collaboration is important. And in my working with families, and I've run family groups and sibling groups, and I'm also a family member in recovery, I know that families have access to many resources, and that collaborating with them and the caregivers will also help really connect the person to the community, where the resources that they may not have realized were right in their area or right in their neighborhood. And family and caregivers are so important to the process, and having that mediation and conflict resolution is important, and also the training. So we're looking forward to this component and those who will really work in putting these components together. Thank you, Yumi.
And you know, as we're talking, Brenda, one of the things that comes up a lot, as you know, because of the co-occurring disorder with substance use and mental health, and particularly with younger folks, is that the parents get confused because they get different messages. I mean, they're very often not aware of integrated treatment, and they get different pieces of information. The psychiatrist is saying that that the individual has to deal with their substance use first before we can do anything about the mental health condition, and all sorts of mixed messages, and you know, creates a conflict and anxiety for the loved ones who are supporting the individual. So all of this is very key when we're talking about co-occurring as well.
Yes, yes.
Next slide. So because this is kind of a complicated process, this new Medicaid managed care process, it's really, really key to also help the family of choice to understand what that whole process is. And, you know, sometimes they may understand it better than the individual. And in order to be of valuable support, it is important for them to understand the process of, you know, the development of the plan of care, and that it should be a collaborative approach, that there are options for developing crisis prevention and safety plans, and that once the individual gets to the provider level, and depending on what the plan of care, you know, in general outlines in terms of support, the more detailed sort of nitty-gritty, if you will, individual recovery plan or service plan at the provider level is also obviously very key to delineating specifically the plan and how the support can happen. It's also important to train family of choice on, you know, the importance of integrating into the community and helping the individual advocate for themselves, in addition to the family helping with advocacy, again, to help the individual. So advocacy is a very, very key component. And oftentimes, you know, we know the individual and family members find it difficult to advocate, particularly when working with mental health or substance use professionals, and clearly stating what they want as well. training on behavioral interventions. So what do you do when somebody does get very angry or agitated or potentially on the way of being violent, even verbally abusive, for example? How do you deal with those situations in a productive way? Then we also want, oftentimes, like for me, I would like some of my supporters to know more about the specific mental health condition. So I have bipolar disorder, and there are specific issues around the disorder that I would want my family of choice to learn and understand, and what supports may be specifically helpful for my particular diagnosis. And the other thing that's key is, and I hear this a lot from parents, that they may be financially strained and they need to help the loved one obtain benefits of different kinds, whether it's financial benefits, SSI, food stamps, supportive housing, particularly I hear a lot. And so it's important to give them information on what's available and how someone may obtain these benefits, and to refer family of choice to resources that specialize in these particular benefits. So that kind of sort of practical knowledge is also very key. Brenda, you want to add to that?
Yes. So, especially for persons in recovery, I have seen where families have become the greatest advocates for the person in recovery. So training on community integration and self-advocacy, and helping the family being supportive and helping the individual learn to self-advocate, but also helping the family know that they can have a voice as well. I think, in some areas, but also helping the person in recovery to own. We talked about the individual recovery plan and assisted family and understanding the various requirements of it. And I think for us in the addiction services and looking at recovery-oriented systems, it's really helping the family understand that the person in recovery has to own their own recovery plan and how important that is, and helping them to do that, and making sure that whatever is happening is related to their plan of care. And also, for example, training on behavioral intervention strategies. I've thought about how important it is, for example, to have individuals understand the stages of change, for example, and help put things in perspective and the interventions that relate to each stage. And so for families, they don't always understand the process that a person has to go through, and helping to train them on these behavioral intervention strategies gives them an understanding, and they can then begin to understand the process that the person has to go through based upon where that person is in their recovery process. So I think that these components are extremely valuable to assisting the individual and empowering them in their recovery and assisting the individual to move forward in their recovery. Families are extremely important to that. Thank you.
The other thing I want to mention in terms of also crisis prevention, and I'm sure many of you know about the Mental Health Wellness Recovery Action Plan, and there may be something comparable in substance use, but having that implemented in terms of helping with the sort of operationalization, if you will, of the RAP plan, to have the individual, or let's say the provider, to be able to help the individual implement that RAP plan where it involves the family. is a key component of providing the service as well.
Yeah.
Next slide. Oh, sorry, go ahead.
I'm sorry, and just to piggyback on that, for us in Oasis and with persons in recovery is looking at their relapse prevention plan, and also looking at that the strategies that they need to put and implement their relapse prevention plan, and having the family understand that is important.
Yeah, and oftentimes there may be components of, at the RAP plan, you list who your supporters are. Right. And so it's important for, obviously, the service provider side and the family side to know that they are incorporated into that plan.
Yes.
Next slide. Okay, so when it comes to how, in what kind of setting and how the actual service should be provided, you can obviously have, it must be face-to-face, okay, that for sure. And as I mentioned before, you can be one-on-one with the individual, one-on-one with the individual and the family of choice. And of course, with groups, the same situation, the individual can be part of the group, or they may not be. But again, the subject of the conversation around that group should be connected to that individual plan of care and individual recovery plan. In terms of the setting, it can be in the home. Sometimes, people find it very comfortable to be in that home environment, and it's good to see sometimes the physical layout of the home situation, particularly if they're living together. In the community, meaning it could be that someone prefers to be in a sort of safe or objective environment. Maybe it's in a setting in the community, but makes the individual more comfortable as a meeting place. And then, of course, at the program site or the counselor's office is another option. In terms of the eligibility, or let's say the admission to the service or to the program, of course, the key central to this is that, even though the care manager, if there might be a situation where the care manager feels or sort of like pushes the individual to say it's important for your family to be a part of it, and the individual doesn't want it, then that's the rule. The individual has to decide whether they want the family to be involved or not, and they have to show a clear stated preference that this service is needed and wanted. And in order to do this, obviously, if you're having communications with the family of choice, the individual must give a formal release of information and communication for the staff person to contact the individual. And the exception is that, of course, if there's a real threat of injury, serious violence, death, suicide, that's a sort of extraordinary case outside of this criteria. Brenda, did you want to mention something here?
No, I think you covered everything there.
Okay, great. Next slide. Okay, so in terms of billing, okay, and as you all know, each of these services has a cap in terms of how many hours can be provided in a calendar year, and this particular one is 40 calendar hours, and it does have to include all the hours, whether it's individual or individual with the family, so any of the sort of allowable settings and modalities must be included in the 40 hours. Now, these services can be provided by both mental health professionals as well as paraprofessionals, and oftentimes there are certified peers that have been trained in modules specifically on family support and training. So these folks can certainly provide people with CPRPs, certification for psych rehab practice. I forget what the acronym stands for, but it's another sort of paraprofessional accreditation, if you will. In terms of the ideal and case limits in terms of caseload, from the staff member perspective to client ratio, or shall I say the individual that you're supporting, should be 1 service or direct service staff to 15 individuals receiving the service. And for support groups, you know, you don't want them to get too large, and it gets very unproductive. So the best is to keep it to a max of 16 group members. And again, the group members can include the individual and the family of choice, or it could be a situation where the individual says, you know, I'd rather the family members be in a group without me being educated or supported.
And Yumi, just want to say that, you know, with the 40 hours, it really winds up to be, if you look at it, if you divide it to 12 months, it's like 3 hours a month. So it is possible to do something like this. Don't look at the 40 hours as a short period of time, but it can be effective. And we're looking forward to even the certified peer advocate, that is the, for the addiction side, the certified peer advocate can also be one of the providers for this service.
Yes, I totally agree with you. It is important to look at the hours, the capped hours for all the services. Me as a consumer, I think they're pretty good actually across the board. So I agree with that. Yeah. Next slide.
So with that, we're actually going to turn it over to Kinsey McManus at NAMI. Kinsey, are you there with us?
I am here.
Excellent.
So thanks, Dan, Brenda, and Yumi. I did want to just touch quickly on something about, you know, obviously your client member or patient, however you identify, has the right to choose whether or not to have family involvement, but because family involvement has not been included in standard practice services, it is really important for us as providers to at least test the waters to see if there's an interest, because it's not going to be traditionally thought of. And so, you know, often our clients don't always think to say, hey, yeah, maybe I would like my family involved. So I just wanted to throw that out into the ring as well. So my example is regarding Karen. She's a 24-year-old woman, and she's currently living with her parents. She experienced her first psychotic episode at age 20 while attending college, and has since been formally diagnosed with schizoaffective disorder. And at the beginning, you know, she was experiencing frequent hospitalizations. Since she's not been hospitalized for over 6 months, she's currently receiving outpatient care through a clinic. And in conjunction with her treatment team, you know, she's really decided that she's ready to return to part-time college. You know, at this point for her, she's feeling much more under control of her symptoms. She's got a team that she trusts, and is feeling, you know, comparative to her peers, a little behind the game, and wants to kind of return to something that's very positive for her. Unfortunately, because her parents went through the process of her having her first episode while in college, they're very concerned about there being, the return to college being a huge trigger. And this is really very common, we've seen in general when it comes to family members and their relatives, that, family members sometimes have these very, very high expectations of their loved ones, or have very low expectations of their loved ones because of the experiences that they've had, and either are really wanting their loved one to move faster through the recovery than the person is ready, or, is very hesitant and wants to protect the loved one from kind of taking these steps. So, part of our role and the beautiful new thing about these family support services is that we now have an opportunity to help families get on board with their loved ones' plan and process through their own recovery. But again, I think as Brenda and Yumi have kind of both touched on, that sometimes family members, although incredibly well-intentioned, really do need some support and education to understand these kind of underlying belief systems around, person-centered recovery and really letting their loved one make the decisions and drive their treatment. And again, sometimes family members go into the far extreme of saying, well, I'm not going to be a part of this at all. So in this instance with Karen, the parents are really concerned about it. Karen has expressed to her treatment team and her care coordinator she's really not willing to return to college unless she does have the support of her parents. She'll be living with them. They are key to her support system, and she wants their support. So there's a few different options that we could have as a result of these new services. One could be that maybe your clinic often does serve kind of this transition-aged young adult population, and you're noticing that there are quite a few discrepancies between the young adults living in recovery and their family when it comes to maybe returning to the workforce or returning to education. And so it might be beneficial to hold just a general workshop for parents on boundaries, person-centeredness, and kind of goal, helping family members kind of get on board with the goals and working with the treatment team. But maybe in this instance, Karen really feels like it would be best for her to be involved in a discussion with this third party, with you as maybe the outpatient provider, as the third party to have this discussion. So you're doing more something along the lines of family mediation and conflict resolution, so that everyone can kind of put their cards on the table and the family can really hear where Karen is coming from and why she feels ready for college and why the treatment team also supports that decision. So through family support, we can really bring family members along when they may be off kilter with the person living in recovery and the rest of their team. Okay, so now I think.
Terrific. Thank you so much, Kinsey. So we're now passing the ball back over to Brenda, who's going to walk us through a substance use case example.
So I'm thankful that we had someone that submitted this case example, and I think that this will be very helpful to really help understand how it looks in the substance use disorder field. So in this case, we have a 19-year-old woman that is in treatment following a near-fatal overdose, and this person had a 10-year history of addiction, and her family included her father, stepmother, and 2 brothers. With the exception of the father, family members had distanced themselves from the client, and we find that that's typical, that is due to the long history of addiction, that there is a lot of times distance that's been put in between the person and their family, and as they say, some people have burned bridges, and it's very difficult for them to reconcile. Now the person is in treatment and wanted to reconcile with her family, and as she began to understand the importance of having them in her life, she wanted to address this. And this particular program that she was in had family support services available, and they provide 3 family support groups for the individual to engage the client and the family into treatment, which will result in family reunification and serve as a tool for relapse prevention. So that's one of their goals. And the family support addressed the following through workshops and groups. It really helped to development of methods to best support the client. How could they best support her in her recovery process? What were the things that they need to learn and recognize? They needed to also be able to see for her, to be able to look at the person and not, so this person was a heroin addict, so not to look at the heroin addict, but they were shown how to look at the person as their daughter or their sister, because many times we look at, and especially in addiction, look at the behavior and not at the person. So really, they gave them an understanding of that. The family was educated on how childhood pain, experimentation, and other contributing factors really facilitated this person's addiction. They may not have gone into great detail, but they were able to help, in a general manner, help them understand how this pain, childhood pain, experimentation, and other factors contributed to her addiction. They were able to guide and explore chemical dependency, what the effects are on the individual's personality, and the dynamics of the individual. When they educate the family, they really looked at what is treatment, how long is the process, what types of group is the person taking. They gave them some chemical dependency education, what happens when a client uses drugs versus the loved one they know who is vastly different. They discussed addictive personality and the dynamics of the lifestyle of addiction. The family was educated on how to communicate with the client during the process, because this person was in a residential program. The family was encouraged to be aware of expectations, because many times, as Kenzie said, family have certain expectations on the person and how that recovery process should happen, whether it should be going faster than it is or slower than it is. They also begin to talk about things like enabling. And so for addiction, enabling is a big part of the picture with families, and really looking at the addiction enabling versus supporting the person, because many people wind up enabling the person instead of allowing them to direct their process. So it was really important for them. So guidance and interventions were directed towards improving the ability to communicate and most effectively with the client and support the family roles in recovery. During the process of the family support with this client, the family was moved from a place of blame and disconnect to a place that helped them understand the factors that contributed to her education. This client had ruined all of her other family relationships except for her father, and the family process took place, and in their learning, she was able to reach out and to actually restore a relationship even with her eldest brother. Even though some of the other family members came, the eldest brother didn't want to be bothered and didn't attend the family sessions because he was not convinced that she had really changed. And so he was invited to a particular event at this place and facility, and when he was able to observe the person and really see how happy his sister was, it really changed how he viewed her, and he had never witnessed her in that kind of environment, and visibly seeing the changes, it really changed how he looked at her. The client's father always kept in contact with the client throughout her process and sought guidance when in doubt. He even was able to seek guidance. And I think the process also let them see that there were other supports out there. So there was actually linkages that were made for the family outside of this supportive group that they can keep in process and for long-term or short-term. The father actually was, she was a part of the Access to Recovery program, which made family therapy available, and the father was actually able to enter into family therapy. And midway into the process, the client's brother consented to being a part of that family session. The results of all of this and the collaboration of all the above services resulted in a mutual understanding and respect for the process of addiction that was evident. the family did not ride off into the sunset, but forgiveness took place and relationships blossomed. The siblings and father attended Al-Anon as well, so they were referred to another resource. So there was family therapy they were linked to. They were also linked to Al-Anon to assist them further. And, you know, they're still a work in process. The stepmother still is kind of resistant and still is not sure of the change, but that is something that's still being worked on. And, you know, this is really, really helpful and help the person in their process of recovery. So this was an example of really where there was great benefit for the person. It would renew family relationships, and it created an environment that allowed the client to benefit as much as possible from the parent, from the support of the family. And when you see families, especially in addiction treatment, families supporting a person, the person's recovery is greater. There's a greater opportunity for recovery. And when I ran focus groups, I saw that especially for most people, when their family is not accepting of them coming back into the community, it really impacts how they recover. So this was a really great example of how this support, family support, can really aid a person. Thank you.
Great. Thank you so much, Brenda and Kinsey, for those really helpful examples to take kind of the nitty-gritty of the home and community-based services and to put a real-life face on it. So we really appreciate that. With that, I'm going to turn it over to Boris Vilgorin here on our end just to talk us through a couple of last slides, and then we'll jump into Q&A. So please be sure to send those questions in using the chat feature on the right hand of the screen.
All right. Good morning, everybody. So I'll just take the group through a couple of slides, as Dan said. So the first slide we have up, we just wanted to remind folks there are manuals on all HCBS services that are available on the website. And here are the links. And again, if you printed them out or go to the website directly, you know, they'll be there. And of course, since this presentation is on our website at MCTAC.org, you know, you can take it from the presentation directly. Let's just move to the next one. So also just walking folks through other types of webinars and presentations that we're going to be doing, some that are already completed, of course. So we just wanted to put that out there for folks who might be interested in the Managed Care 101 or contracting and the billing trainings that are coming up. And more information will be coming out. So please look out for the registration and information on these webinars. And just to go through the schedule of the HCBS, we completed, as earlier was said, the peer supports earlier this week. This one is the family support and training. We have employment coming up next Tuesday, employment and education, non-medical transportation the following Friday, and then the rest of the trainings on respite crisis and psychiatric rehab, rounding it off and completing during the month. And if you're interested and have not registered for those, again, you can log into the MCTAC website and register for those trainings. And as a reminder, we always welcome, you know, any questions you might have. Our, you know, the email address for the question is mctac.info@nyu.edu. Please, you know, if you have any questions regarding this, you know, training or webinar and any other questions in regards to the managed care transition, please feel free to email. And without any further ado, we'll turn this into, you know, our Q&A portion of the presentation. And what we'll do is we'll read off some of the questions, and if we can answer it, we'll go ahead and or myself will answer it. And if it's directed more towards our presenters, we'll ask the presenters to answer the questions. So with that, I'll turn it over to Dan.
Perfect. Thanks, Boris. And I'll just add to that that the questions and answers that are discussed on the webinar are all compiled and aggregated into FAQ documents that are kept on the MCTAC website. So that's under the Tools and Resources tabs at MCTAC.org. So you can look back and see Q&A from past events there. And we'll continue to build out what's currently there as we move forward with some of the different topic areas and domains, including home and community-based services. So the first question to come in today was actually towards the beginning of the webinar, so thanks again to folks for sending these in as they come to mind throughout. Does the family member participating have to have Medicaid themselves in order to bill for the service, or is it billed through the identified consumer's Medicaid?
So I'll jump in and answer here, and I'll ask Yumi or Brenda to jump in or correct me if I'm wrong. My understanding is the family member does not have to be Medicaid or have Medicaid. These services are billed through the consumer, and of course the consumer would have to be in managed Medicaid and have Medicaid. Brenda, Yumi, I just want to confirm that. Is that accurate?
Yes, absolutely. Everybody should note for all of these services, you know, the billing Medicaid number, of course, is centered around the individual and providing that individual the services. So pretty much in general, you have to have the Medicaid billing of the individual who is qualified to receive those services. So that's where the focus is.
Okay, thank you.
So another couple of questions just off the top that I think we might try to answer on our end and look to Yumi and Brenda to chime in as well. Can family supports, or for that matter, any HCBS service, be delivered to adults who are receiving Medicaid reimbursed rehabilitation in OMH licensed community residences?
Right. So we have a couple of questions similar to that. So we would direct the individuals to look at the chart that we presented as part of this presentation that talks about, you know, which services in combination with others could be presented, you know, are allowable. So please refer to the thing. Then there you go. We should be on the screen right now that indicates what combinations are allowable and not. And we have a number of questions on that. Again, Yumi, Brenda, anything to add?
Yes, I believe we have also the billing manual. It's a draft still, but it also comes with a, I forgot the name of that document, that's connected to the billing rates and what they can be combined with. I believe they're up on the OMH website. And I don't know if it's up on MCTAC, but we might want to put the draft up there.
Yeah, so we have the link to the billing manual on our website and also in this presentation. So, all right, thank you, Yumi.
Great. And this one actually will go back to Yumi and also possibly Brenda. So during the presentation, you referred back to an individual's recovery plan. And so were you referring to the plan to deliver this particular service or the overall plan of care through HARP?
Okay, good question. That confuses a lot of people. So once the individual, okay, sits down with the health home care manager and does the full assessment, which is a conversation, and I just want to go back to what was said in terms of the importance of family support or family of choice, let's say, support, and that will be part of the assessment and part of the training of care managers in terms of its importance. But once that assessment is done, the collaboration with the individual and the care manager will develop that plan of care, and that's the general plan of care, which sort of delineates which services and maybe some higher level, what kind of support the individual might need. Then once the individual chooses the specific provider for that service, so let's take family support and training They choose a provider, they go to the provider and sit down with a counselor, let's say, or a peer specialist, and talk about what the issues are. Then they will build what's called an individual recovery plan. That's at the provider, and it's equivalent to what we normally know of as the individual service plan, which goes into much more detail about the specific services and the duration, the intensity. So that's where there is the distinction between the overall plan of care, which is done with the health home care manager, and then the individual recovery plan, which is done at the direct service level.
Great, thank you. And so this one we could spend a little bit of time on. So I might ask Yumi, Brenda, and Kinsey if they're able to chime in here on a more general question. But we'll take a shot off the top here. So where can family go to access these services for their loved ones? So specific to this presentation today, the services, the family support that we're talking about is for HARP-eligible individuals who are designated by New York State and then go through an assessment process through their respective health homes to determine which HCBS services they're eligible to receive. But Yumi, Brenda, Kinsey, if any or all of you wanted to just chime in beyond just specific to HCBS, where families can go to access family supports for their loved ones in these situations, I think that would be really helpful for folks on the line.
This is Brenda.
NAMI?
So,
I would say NAMI.
I was going to say NAMI.
Yeah,
always NAMI. You know, the person will have a care coordinator, and so the responsibility of the organizations that are providing family support services are to make relationships, contractual relationships with the different managed care plans. So the care coordinator should actually be the one that knows what agencies are connected in with them to make the referral for family support services.
Right. So you know, you providers out there have been designated for very specific services. And so those of you who have contracted with the managed care plans and have been designated for family support and training, and the managed care plan wants to contract with you for that particular service, you will be on that sort of provider network directory. So you know, with all of us, we have insurance, we're looking for a cardiologist, we'll look at our provider network directory and choose one, and we could look at the background or the experience of the particular provider. And then that individual will make the choice of which provider they want to provide that particular service. And, you know, if they're unfamiliar with the service or the array of providers, then they can sit down with the care manager to figure out which one might be the best match for you.
Terrific. Thank you both. So another question that came through, is there a cap as to how many supporters a person served can identify to receive family support services?
Okay, I'm not sure what the question means about supporters. Since the service is, again, focused on the individual can decide whichever supporters and any, you know, number of what they feel are close supporters and want to be educated and supported to help the individual. It's not the cap on that, but the number of hours that are given in terms of family support and training services to that individual. I hope I interpreted the question correctly.
That was our interpretation as well.
Right, and this is Brenda, because I think also that there is, in a group setting also, there is a cap on the number of people that can be in a particular group, and there's 16, so for each counselor or provider of the service, there can be up to 16 people in that particular group. So you can't have a family of 20 sitting in one group. So that will also have a cap on what would take place.
Right. And on a similar note, we got a question about the group participant allotment. So we're not exactly sure off the top, but again, when we're not sure, we'll capture the question and run it with the policy folks, usually at the state level, to see if we can get some guidance. But if any of the folks on the phone can shed some light on this. Did the waiver increase the Medicaid maximum group participant allotment to 16? The questioner believed that Medicaid usually had a maximum of 12.
So yes, that is the typical. With HCBS, it's a little, because it's a new animal, shall we say, we've proposed different. We haven't gotten the final okay in terms of the nitty-gritty. I think they're, working on that, tightening that up and finalizing it shortly. But it's not specific to the waiver necessarily as much as what we proposed we'd like for CMS to approve on a particular service.
Right, and so this is Boris, just to again underscore that we're talking about, as Yumi just said, and we're talking again HCBS specific rules. So if there are different requirements in different programs for Medicaid or the state, this of course would not be affecting that as a kind of a general change in those protocols. As Yumi said, this is very specific to this service, and again, we're still looking to finalize even that, even for this service. So just to clarify. So let's move on to the next question.
Is there a certification or credentialing process for family support providers to families of adult clients? Is it different from family support in youth services?
So there's not a specific certification that's mandated to be billable, but if you have a peer specialist, for example, who is certified, having them to provide specifically family support and training, then that individual or that service provider should definitely have some training and education and experience on providing that particular service. There are certifications out there in the universe, but that's not required to for that direct service staff to have.
Okay. Great. Thank you.
This questioner says that he or she understands that the modality for family supports is face-to-face. However, can there ever be contact made by phone? If yes, in what instances?
So I'll jump in here and answer, and again ask Yumi and Brenda to clarify or correct me. So right now the requirement for billing purposes it is a face-to-face, but I do know OMH and Oasis are looking at the possibility for some instances to be telephonic, but as it stands right now, it is a face-to-face. I think if there's any change and if there's any instances where this might be appropriate, again, for billing, further information will be coming, at least that's our understanding. Yumi or Brenda, is that accurate?
Yes, that's absolutely accurate. There's been an ongoing discussion about that, and it depends on the particular service where CMS might be okay with it, but for now, it's absolutely face-to-face. I think it's on all the services, yeah.
Right, and I think that it's more beneficial to have the face-to-face service. If it is, I think, considered, it would not be the main focus of the service being rendered by phone.
Great. So on one of the business and billing rule slides, I believe Yumi talked through limitations and exclusions, and that the total combined hours for family support and training are limited to no more than a total of 40 hours in a calendar year. And so the question is, are those 40 hours per client or annual total per program site? And my understanding is that that's per client, but Yumi, did you just want to confirm?
Yes, all services, again, center around the individual, and, you know, you're billing on that individual's Medicaid number. So, you know, it doesn't matter where the person goes for those particular services, but they know, I mean, as all our insurance, you know, you may be capped at 12 site visits a year or whatever. It's the same here, where it's the individual and what their sort of plan of care has decided that the hours would be for their particular service. So it's not by the service provider, but the individual's cap. And so, you know, that will have to be tracked, you know, for the individual.
Great. We got a what we call a low-hanging fruit question, is if the chart that we pulled up before that shows which programs can do which services, that's available online. And just as a refresher to folks, so all of the charts and the slides themselves will be are now available through MCTAC.org, either listed on the tools and resources page for our general resources and links to outside materials. And the slides themselves are captured under the events page. So if you click on the HCBS services webinar series, all the recordings and slides for each of these presentations will all be available centrally there. And then a question came through about individual recovery plans and assessments. So, excuse me. So it's likely that an individual will receive more than one HCBS service at a given time. Will there be a separate individual recovery plan for each service? If so, will they be shared among the various service providers?
So yes, every single HCBS service, and yes, the individual can certainly may very well qualify for more than one type of service. But when that individual goes to the particular provider, you know, let's say for supported education, I go to a provider, they're going to have to put together a specific individual service plan for the employment services and the employment goals that individual would like. And of course that will include duration and intensity of services, because of course that goes to the billing as well and utilization. So the managed care companies are going to obviously want to approve and see that. If you're talking about the individual recovery plan or the, let's say, service plan that the person has with each service provider for a different service, we're not clear on that yet. We haven't decided that yet, but certainly the plan of care at the hub where the health home care manager is will be shared with the different providers. Am I correct on that, Boris?
Yes. So I think we have one more question that we'll take and then wrap up.
So groups are specific to the individual. Are mutual aid groups allowed among various families dealing with similar issues?
So that's what we meant by the family support group. So obviously it's mutual aid, but at the same time it's specific to the subject matter that's relevant for every individual. So let's say you have 3 Medicaid beneficiaries who want their loved ones to be trained on medication regimens. So the entire group that's there, they can provide mutual support, but it has to be, again, centered around the particular topic. And they can share information, you know, maybe what's worked for them, that they can support each other with ideas. But again, the focus is it must be relevant and around the topic that's connected to the individual recovery plan.
That's great. Thank you, Yumi. So we have a number of other questions that really relate to upcoming and different trainings, things like, you know, will there be training on the individualized service plan? Yes, there are going to be more, you know, there'll be trainings that are being developed by different organizations, including MCTAC. So I strongly recommend you look out for that. There's also more in-depth questions about this particular service. And so the other piece, just to remind folks, this was meant to be more at a kind of a 30,000, 20,000 foot view of this service. And we're looking to fall, early winter to do, you know, in-person, more in-depth service cluster discussions. And so those registrations and the information on those will be coming out probably in coming weeks. And that's where we're going to be really diving deeper into more of the kind of the nitty-gritty and some of these questions that are currently coming up in regards to, you know, the state plan services, clinics versus HCBS or other types of questions. So we'll be doing that as well. And so we just wanted to mention that. And again, thank our participants to being on the call, and thank you for all joining in. And Ben, any last?
Yeah, I'll just echo Boris and thank Brenda, Kinsey, and Yumi so much for joining us today and providing some great information. And again, for folks, the slides are available on MCTAC.org, and a recording of the webinar, if you'd like to revisit anything or share with your colleagues, will be posted next week on the events page. So enjoy the rest of your Fridays and have a great weekend, and we look forward to seeing you next time.